And so how do you study for pharmacology? You cannot approach this client needs category the same way you approached it or did it when you were in nursing school. Studying for NCLEX pharmacology is different. At this point, remember, we're not trying to be pharmacists. You just care about NCLEX drugs, okay? And you just care about the way it's presented to you on the NCLEX. Again, unless you want to be a pharmacist, please don't do this the way you do it or did it when you were in nursing school, okay? So step one to studying for pharmacology is to be familiar with your drug classification. And let me tell you, let me support this and back this up with some facts. So every year, NCSPN does their yearly conference. This year is online because of COVID-19. But every year we travel to the conferences because these are the folks making up the exam. They go over everything with us, how they make the exam, how it's adaptive, you know, what's changing, what's not changing. So I can think at least 2-3 years where, you know, when they go over this, we always have the same question where we ask them, you know, go through with us because this is, I know, a topic that students struggle with. So we always ask about the pharmacology section. So they tell us, and by the way, this is in the Q&A under ncspn.org. And if you're not familiar with that, do look at another webinar that I've done in the past in reference to ncspn.org. But the answer I'm going to share with you is on the Q&A section of their website. So NCSPN tells us you should be more concerned with drug classification versus the actual drug itself. Both of them are important, but they say make sure students know their drug classification, because what happens is so often you'll be doing an NCLEX question where they're not even asking you about a specific drug, but they're asking you about the drug class. Okay, so instead of saying the client is on Coumadin, they'll tell you the client is on an anticoagulant. So step one, priority, is to know and be familiar with all of your drug classification. One of the things you get when you do my full review is a list of the drug classifications, okay? But you can always look this up, Google it, get it. This drug classification list, this is a snippet, by the way, of the full document, okay? It's just easier that way via PowerPoint. So this is a snippet of the list of drug classification. So this particular one that you're looking at is a clip, a snippet from the one from the Learning Extension, sorry. So this is from the Learning Extension. They did a very good job with it. So here's a list of your drug classification. You need to go through that list. Most of the drug classification, their names tell you what they do, which is great. Not all, but most of them. The name tells you what they do. For example, anti-anxiety. That tells you that is against. The prefix anti is against. So you'll see all of them, anti. They're against something. You're fighting something. Okay, anticonvulsants. So those are your seizure meds. Antidepressants. So again, most of them tell you what they do. So you need to be familiar with that. Because if I'm giving you a pharmacology question and I tell you the client is on an hypertensive, you need to know exactly what drug class that is. So let's just do a couple of them and then you'll get the point. So step one is to work on your drug classification, okay? And a lot of them have memory tricks, utilize those. So your anticonvulsants, for example, decrease the incidence and severity of seizures, okay, due to different causes. So you know what an anticonvulsant is. So I'm giving you an NCLEX question and it says the client is on an anticonvulsant. That is, your seizure drugs. Now, you need to think of your drug classes as family. So that's the family of drugs, okay? So I'm Riggs. So if I say, well, the Riggs, that's the family, okay? Versus if I say Darlene Riggs, then that's specifically me. So your drug class is the entire family. Okay, if I say the Josephs, that's that entire family. Hopefully none of you are named Joseph. But if I say Martine Joseph, that's that specific individual, okay? So for drug classification, it's the family. So step one is to know and be familiar with your drug class. Now, every class, every family has issues, right? Every family has drama. Every family has little craziness. So every drug class, has these adverse effects that you need to be familiar with. And you need to be familiar with them for the entire family. So if I give you an NCLEX question and it says the patient is an anticonvulsant and I didn't name which one, you're thinking the entire family. So step two to studying for pharmacology is to know the adverse effect to the class. What is the craziness with this family? Okay, so step one is to be familiar with the class. Step two is to be familiar with the adverse effect to the class. So when you study for pharmacology, also start thinking about it in the sense of family. I like to teach it with that analogy because it just makes sense. So if I'm talking about the Riggs, it's the entire family. If I'm talking about Darlene Riggs, it's that specific, individual. So anticonvulsants is the class, but there's specific drugs, and we're going to get into the specific drugs in a moment, but you get the point. Step one, know your classes. Step two, know the adverse effect to your classes. So I also have a list for you of the class of drugs and the adverse effects to each class, okay? So for example, your first one here on the screen says antihypertensives. That's the family. The entire family, you are concerned with orthostatic hypotension. The entire family, doesn't matter who. Doesn't matter if it's Darlene, if it's Mike, my husband, if it's my children, Michael. Nope, the entire family. If I say antihypertensives, orthostatic hypotension, fluid and electrolyte imbalance is a concern for that entire family. Okay, anticholinergics, the entire family. You're concerned about dry mouth, constipation, blurred vision. Anticoagulants, bleeding. So you get the point. So you need to know the drug class and you need to know the adverse effect to the class. Okay, so the moment you are familiar with the class and you are familiar with the adverse effect, you already know what vital signs you need to do, for the client. Once you know the adverse effect, you already know what nursing interventions need to take place because you know the adverse effect. So the moment you know and memorize and understand the adverse effect to a family, you also need to think about, okay, what nursing intervention, what vital signs, to expect. So for example, your antihypertensives, we say we're concerned, the entire family, of orthostatic hypotension. So if we give any antihypertensives, we need to monitor that blood pressure. Okay, we need to monitor the fluid and electrolytes. Okay, and for example, with anticholinergics, there's a lot of teaching with this one because your anticholinergics, the entire family, they cause dry mouth, constipation. So you have to tell this client, you can't take this drug and not hydrate and not drink a lot of fluid, okay, because the adverse effect to the family. So some of them come with certain vitals interventions we're going to do monitoring. Some of it comes with a lot of teaching, okay? So anticoagulants, bleeding, and then depending on which anticoagulant, we'll go even further. So step one, know your drug class. Step two, know the adverse effect to your drug class. And the moment you know the adverse effect, you know what nursing intervention and vitals you're looking out for, okay? I'm going to stop in a moment to see if you have any questions. So after learning your drug class and the adverse effect of the class, it is now time to associate the class with specific drugs, okay? So don't just jump into memorizing drugs and and what they do. No, start with this step. You just make the process a little bit easier when you do it this way, okay? So now we can get into specific drugs for that class, okay? So our first class, well, this is an example. So we're going to talk about the against hypertension. So now we can get into your ACE inhibitors, your calcium channel blockers. And so now the family has subfamilies, okay? Because, for example, I have cousins, right? My father has a brother who has kids, so those are my cousins. So remember I told you, think of pharmacology drugs as a family, okay? So I'm Riggs. So my husband, that's my husband's last name. So he has a brother, right? His brother has children. So if you think of the antihypertensives as the Riggs, some drug classification have different subcategories. Antihypertensives are a great example to go over with that, because you have your RAS, and then you have your ARBs under that umbrella, and then you have your, so I'm gonna go over that. That's why I chose to do antihypertensive too, because it's such a great example with the subfamilies. So now my point is, in the how to study for pharmacology, is after you know your drug class, you know the adverse effect, then you'll want to affiliate, okay, the drug under that umbrella. So for example, under your antihypertensives are the ACE inhibitors, which we're going to talk about in detail in a little bit, okay? I'm using it here as an example of how to study, okay? And then after you affiliate the specific drug under that family, that drug class, then you'll want to know the little special crazy something about, you know, each specific drug. So for example, your ACE, you know, inhibitors, you know, we're going to monitor that potassium. So certain drugs, we're going to look at certain electrolytes, because you know that family, we need to monitor that, okay? And of course, the blood pressure, because of the drug that it is. But you get the point with that. Let me exit a little bit to make sure you don't have any questions so far. So I'm still screen sharing. All right, so let's continue with NKJV Pharm. Nursing priority. Okay. As nurses, it is our job to administer, you know, the medication that the physician prescribed. We need to use the guidelines that are set for us, okay? Because remember, at the end of the day, we need to be safe to practice, okay? And that's what the NKJV tests, that you are safe to practice, okay? So we, as the nurse administering the medication, need to know the implication of the meds, the aspect of how to administer it, which we're going to go over. And don't forget, at the end of the day, you as the nurse, LPN or RN, are responsible, legally responsible, for every medication that you administer. That's an NKJV question. Don't miss it. You are responsible for what you give, even if the physician makes a mistake. So let's say the physician, you know, makes a mistake, order the wrong dose, the wrong rep, and you do it, you are still as responsible. So don't think, oh, I just followed what the physician, you know, ordered. Okay, so don't miss that. You are legally responsible for whatever you give. Okay, so you have to really know your stuff and be in tune to it. So in addition to, you know, you being responsible, well, this kind of, you know, helps you make sure you do it right. You have to know the 5 rights, okay, to medication. You know, we added documentation as well, but you got to give, you know, the right medication to the right client at the right time, the right route. Yeah, these matter. We're going to go over them as we go through the different system in administering drugs. But here they are here in details, okay? So let's go over a couple of them. The right time. We have the 30-minute and 30-minute before and 30-minute after window. It's not an hour, folks. It's not an hour and a half. It really is 30 minutes, okay? So that's another thing. Sometimes we're like, in real life, we deviate from what's written in black and white, which reminds me, if you are an LPN or you worked in the healthcare environment and you have a lot of experience, that is good. Experience is always good. Nobody's ever going to downplay that. But this NKJV is based off of what's in the book. So although you have the experience, don't take the test and you're sitting in front of a question, you're asking yourself, what do you do on your unit, your floor, your facility? No, what does the book say? Because if research statistics shows that new grads, you know, with no healthcare experience, not an LPN, no other background, that it's easier for them to pass the NKJV than an LPN for the RN exam than an LPN or somebody with experience. So your experience does hurt you when it comes to taking the exam, because so often we're thinking, what do we do versus what does the book say? Okay, so be careful with that. All right, let's do another one. Right drug. If you don't mix that drug with the right solution, that's not the right drug anymore. So you see silly little things like that. We always think, okay, yeah, give the right drug, but it gets a little bit more complicated than that. If you don't give the drug at the speed that you're supposed to give it, that's not the right drug. So these things really do matter. You need to go over them in detail because that could very well be a question. Okay, of course, the right client, we need two forms of ID. Just asking Mrs. Jones her name is not good enough. Okay, at least two. All right, so you're gonna go through that in details. Okay, drug names. You need to know drugs by their generic names. I know that's the more difficult name, that's the more complex name, that's the one we stay away from, but that is the one you need to focus on. And NCLEX says they're not likely to give you a brand name, and they will not give you both. No, you're either going to get a drug class or you're going to get the generic name of the drug. So your focus needs to be on generic names, okay? And some of you have to undo damage. I'm guilty too, yep, because the brand names are easier to pronounce. They're easier to remember. So please undo that, okay? Focus on your generic name and not your brand name, okay? So there's a lot of little tricks to help you, especially with the suffix of drugs. So again, all of these documents are in my resources. You get them when you do like a full review because I go through all of the Pharm with you, but there's a whole list of suffixes that help you remember what drug class. Okay, for example, your ACE inhibitors, that antihypertensive drug, most of them, not all, and then Pril. Okay, enalapril, lisinopril. So when you see Pril, you know, oh, that's an ACE inhibitor, that's an antihypertensive. We'll do another one. Your Prozols, okay, those are your proton pump inhibitors, your PPIs. Most of them, not all, and Prozol. Okay, your Sartans, those are your headache medications, okay? So these little suffixes help you to remember the drug name. Use them, okay? Mnemonics, I love mnemonics. Use mnemonics because they help you remember the madness because it's a lot, okay? Controlled substances. A couple of questions about you understanding controlled substances. So, you know, every drug has to be approved by the FDA. You can't just, you know, give something that's not approved by the FDA, not here in this country anyway. So, the DA enforces, you know, the control portion of that. So anything that's considered a controlled substance, all of your narcotics, you know, all of those medications, there's rules for them. Okay. Number one, they have to be kept in a double, okay, 2 locked cupboard. And you need to, if you're the nurse for that day, you have access, but your manager should have access as well. Okay. And if somebody's not authorized, you know, to access, they shouldn't. Okay. Because again, hence the word controlled. So these medications are only given under the physician's order. We nurses, nurse practitioners, you know, have limited access to what they can even prescribe under this category. And whenever we have to waste controlled substances, you need to have 2 witnesses, 2 RNs need to sign off that, you know, I had this milligram, I'm wasting that many milligram, this is how much is left, like every time by at least 2 people. Okay, even in home health, I remember being director of nursing in home health, I would leave the office and go waste medications in the home because we had a lot of children on controlled substances because they're cancer patients, different patients. Yeah, I had to leave and go witness and waste with nurses. You have to, okay? So you got to go over this one again. And that's just the way it is. It's always going to remain that way because, you know, some folks, this is highly abusive, okay? Hence why it has to be controlled. So you don't need to memorize the drugs that fall under each controlled substance schedule category. You don't need to do that. Here's what you need to understand for NCLEX. So there's Schedule 1, Schedule 2, Schedule 3, Schedule 4, Schedule 5. What you need to understand is Schedule 1, those are The drugs that are highly abusive, but very little medical use, okay? So for example, we know heroin is highly abusive. Yes, it is. What medical purpose does heroin serve? So you see my point, okay? Highly abusive, very little medical purpose. Whereas as you go up, you know, with the class as far as number, look at Schedule 5. Schedule 5, those have a lot of medical purposes. Okay, your antitussives, they have a lot of medical purposes, anti-diarrhea, but who abuses them? Nobody. Okay, so that's what you need to understand. The higher up you go in the class, the more medical purpose it has and the less abusive it is. Okay, so that's your controlled substances. Now, pregnancy category. All right. Some drugs you do need to pay attention to their pregnancy category, or if you have a pregnant woman in your question, you need to know and understand the drug that she's on. Should she be on it? Can she even be on it? Okay, so for pregnancy category, you have A, B, C, D, and X. So let's just go over a couple of them so you get an understanding. I had another one. I go back and forth with my description. So here, class A has no risk to the unborn child. That would be like Tylenol, Colace, right? Not a problem. Whereas if you go down to a class D category like lithium, there is evidence that this crosses the placenta and affects the baby. So pay attention to drug pregnancy category drugs. So that's why whenever we have a client on lithium, we want to make sure they're on some type of contraceptive, because a client on lithium should not get pregnant. Okay, that's not a baby that's going to make it. All right, so we want them to be on some type of birth control or something. We don't want them getting pregnant on a drug that's class D category. Okay, so now I'm going to go through the systems, the routes. And each route has a little craziness, not craziness, but some things you need to pay attention to and know. So before I move further to a different category, any questions on what we've talked about so far? You should know how to study pharmacology. You should know that you're responsible for everything that you give. That's an NCLEX question. You should be familiar with your 5 rights of medication administration. You should be familiar with the FDA. So all of that you're good with. Thank you, Tatiana. You're welcome. Oh, I have a Tatiana that just passed. Okay, any questions so far? Okay, we're gonna hit some meat stuff, okay? Could you repeat that of the pregnancy category? Absolutely. So with the pregnancy category, every drug is given a pregnancy category. It has to, okay, before it gets approved by the FDA. There's A, B, C, D, and X, okay? A are the safest, okay? But by the way, if I was teaching OB, I would remind you that you have to teach the pregnant woman they cannot take anything that's not approved by their OBG, okay? That's period. But some of the things we know are safe, you know, are Tylenol and Colace for sure, because they're class A, okay? And as you can see here, class B, there's been some animal studies that show no risk, okay? So class Bs are fine as well, but C, D, and X, because look at C, animal studies show risk. Look at D, there's evidence of risk to the fetus, and of course category X for sure, okay, the risk outweighs the benefits to that one, so you would never give a pregnant woman a category X drug. So I hope you're clear with that one. Please refresh the 5 rights for med administration. Okay, so what I said with the 5 rights, a lot of time, you know, we know them, but we don't go into details as to what they mean. So this PowerPoint, this slide right here will help you with that. So we know we should give the right dose at the right time, the right route, the right drug to the right client, like we know. But I went into a couple of little details. For example, the right time. We in real life have downgraded this one. We watered it down because I know I've heard nurses say, oh, I have an hour. You know, it's like, no, it's half an hour, okay? You have half an hour before or half an hour after the actual due time, not an hour, not an hour and a half. So you do need to, go into a little bit of detail with this one. And I also mentioned another common one, and there's an NCLEX question about this one too. Certain drugs have to be mixed with specific solution. Okay, so a lot of drugs are fine with normal saline, but if you mix it with like a hypertonic solution, it changes the drug. So that would not be the same drug. Okay, so although we know, to give the right drug, but if you mix it or your calculation is incorrect, you're giving a more concentrated, yeah, that's all a big, boo-boo. So that's what we talked about with that one. Awesome. So we were on the route. So let's go over the route. But before we do that, there's a concept I need to go over with you. And this slide is important. There are 2 vocabulary words here that you need to make sure you understand, and those words are on the real exam. And some of you who have taken this test before know that you might have seen some of what I'm talking about. So you see the words pharmacokinetics and then the word pharmacodynamic. We need to break down those 2 words. Pharmacokinetics is what your body does to a medication when you take it. When you take a medication, your body is going to absorb it. It's going to distribute it. It's going to metabolize it. And then it's going to be excreted out of your system. That is pharmacokinetics. Pharmacodynamics is what the drug does to your body. You take a drug, sometimes we take a drug and we want it to mimic what our body already does. Sometimes we take a drug because we want it to make our body stop doing something that it's doing, okay? One great example are your antihistamine, okay? Those of you who have allergies, I do. So you take the because you don't want all that, runny nose, sneezing, throat itching. So it's you're making your body stop making all of that antihistamine. So pharmacokinetics is what your body does to the drug, absorbs it, distributes it, metabolizes it, excretes it, you pee it out, you poop it out, it gets out of your body. What goes in has to come out. Okay, that's through pharmacokinetics. Pharmacodynamics is what the drug, the D in dynamics, what the drug does to your body. Okay, so gotta break those 2 down. Now, before we start talking about drug administration via different routes, there are 2 organs that we need to go over. Okay, vital. Whenever you're administering medication, make sure those 2 organs are working properly. And those are the liver and the kidney. Okay, the others matter too. They're important. Yep, absolutely. However, your liver and your kidney need to be functioning properly. And let's go over why. Okay. And when I do test taking strategies and, throughout the full review, I emphasize to you, you need to know why. Okay. That helps you build critical thinking. Why is the liver and the kidney important when I administer drugs? Let's go over that. So the liver, we'll do the liver first. Metabolism. The 2 people or 2 groups that you're really concerned about when you're administering drug is the young and the old. The young, I mean newborns, okay? The younger the child is, the more concerned you are, and the elderly, the geriatrics. And here's why. As you get older, your liver mass shrinks. There's nothing you can do about that. It happens with age, okay? Hepatic, the liver, blood flows and enzyme activities decline. It goes down. There's nothing you can do about this. So the older the person is, the more concerned you are about that. Metabolism for a 65, 70, 80 something year old drops to half to 2/3. That's crazy. So you cannot give the same dose you give a 35-year-old to an 80-year-old. You just can't, because their liver doesn't function at the same rate that it used to when they were in their 30s. It just doesn't. So their enzymes lose ability to process and metabolize and break down drugs. So what happens? The drug stays in their system. The half-life of the drug prolongs. Okay? So that drug stays in their system longer. They're going to get toxic. Okay, especially if you're giving the dose that you would give a younger person, and then let's say that drug is every 4 hours, and then you give it again every 4 hours, it is the half-life has lengthened for that person. They're gonna get toxic. Okay, so the liver is important. Another organ that's even more important than the liver, okay, the kidneys. All right, so again, the young and the old. Oh, by the way, with the young, their organs are not fully developed. That's why you're concerned. So if you give them a high dose, same problem. The liver and the kidneys and the other organs, they're not fully developed to handle that full dose, okay? So the young, you're concerned because their organs are not fully developed. The elderly, you're concerned because it's declining. That's just life, people, okay? So now, kidney, renal. What goes in must come out. The majority of the way that your drugs get excreted is via the kidneys. It also comes out, through absorption as you defecate, yes, 1% of it, but the majority, kidneys, okay? So in the kidneys, we have renal blood flow. Okay, so blood is flowing throughout the kidney is cleaning it out, it's holding on to getting rid of depending on what's happening in your bloodstream. So that glomerular filtration, as you get older, okay, the secretion, reabsorption rate, the functioning of your kidneys decline. Okay, it's just what it is. There's nothing you can do about it. As you get older, your kidneys don't function as well as they used to when you were younger. Okay, so blood flow and waste remove slower. So that means this stays in your system longer. Again, the half-life last longer, so they will get toxic. So before you even give a drug to anyone, make sure their liver and the kidneys are functioning. For example, if they have a low GFR, glomerular filtration rate, you want to hold on to that drug, because how is it going to get out? It's not. Okay, so you want a GFR of 60% or higher, okay, or else, yeah, process that. So you get an NCLEX question that tell you you're dealing with renal failure client or low GFR, glomerular filtration rate, hold up, okay? Because how's it gonna come out? So before you give drug, these two systems, need to be working properly. Now, first pass metabolism, everything you get by mouth goes through what we call the first pass, or AKA the liver. Okay, when you give something IV intravenously, it doesn't go via the liver. Some rectal drugs have a certain small percent of first pass that goes through the liver, but a small percent. But if you're giving it by mouth, it's gonna go through the liver. Okay, so 90% of oral medication is metabolized through the liver. Okay, so keep that in mind. We call that the first pass metabolism. Very important. So now we're going to go through these routes, okay? Boom, boom, boom. Let me make sure you don't have any questions, because again, remember, I cannot see the chat when you're giving a medication. So first of all, oral medications come in so many different forms. It could be a capsule, it could be an elixir, liquid. We do those a lot for children. Could be powder, where like I just had to give my daughter antibiotic infection. I mixed the powder with fluid. So it comes in so many different ways, especially for the children. A lot of them can't swallow tablets, so we have to be creative, okay? Even my 11-year-old, I'm like, you swallow big pieces of meat. How can you not be able to swallow a pill? It's mental, but that happens. So these drugs come in different forms for those who can't. And then you have patients who can't take it by mouth. They have a peg tube, whatever the reason, but oral comes in many different forms. The other thing you need to remember with oral route, some drugs come in what we call extended release. So whenever you see CRX or XL, don't crush those. That's an NCLEX question, an easy one too, so don't get it wrong. Extended release drugs, time release drugs are not to be crushed, are not to be broken in half, or not, they're coated especially, and they're supposed to be released in your body throughout a certain period of time. They wouldn't melt like that if you drop them in water, okay? Because if they're meant to be released in your body that way. So hence extended release. When you are, whether you have food in your stomach or not, when you're taking oral medication, it matters, okay? Food and GI motility, okay, as your bowel movements move, affect how quickly the drug gets taken into your body. Let me give you an analogy, an example that you'll understand. So when you drink alcohol on an empty stomach, you get a buzz quicker, don't you? So a lot of time folks will tell you, eat something when you have a buzz. So same analogy here. You take drugs on an empty stomach, it gets absorbed a lot quicker than with food. You know, as a matter of fact, sometimes based on your signs and symptoms, we'll tell you take this, you know, with food to decrease some GI effects. So it depends on how the drug is made, the type of drugs, okay? So sometimes, yeah, we'll tell client, take it with food or take it on an empty stomach, depending. Now, if there's food, it absorbs slower, okay? Because again, same analogy, the food that's in there causes a slower motility, okay? Absorption is slower with food, milk products, or some medications like tetracycline, especially your antibiotics, yeah, for sure. So pay attention how drugs come. There's a list that I give students. Who was it? There's I want to say it was Elsevier, but one of them came up with a really nice chart. I love seeing information organized because that's how my brain works. So they put out a nice little chart that says drugs you take on a full stomach, drugs you take on an empty stomach, drugs you don't take with grapefruit or grapefruit juice. Like there was a nice, beautiful list. So I do pass that on to students because I really like it. It did such a wonderful job in categorizing the list. And that's also NCLEX based, which is all we care about, okay? So that's the thing with oral. A couple more things with oral medications. Great, but not for emergencies, okay? If the client is unconscious, that's not the route for them. We're gonna go IV. So silly little things like that you have to remember, okay? And I know some of what I'm saying, some of you may already know, but don't take it for granted, okay? And for example, if you're taking it by mouth, it will most likely cause the GI problems, right? The nausea, the vomiting versus something intravenously. So think about the route, you know, that you're giving it with some of the signs and symptoms to the drug. So here's a great example. Antibiotics may also kill normal floras. So that's why we always encourage probiotics post antibiotics, okay? Because you want to put those good bacteria back. So a couple little things you need to remember about oral. But NCLEX question, not suitable for those who are unconscious or nauseous and vomiting. And it makes sense, okay? And again, not for an emergency. Like by the time it gets processed, you know, through your stomach and your liver, yeah, you're done. If it's an emergency, I need to choose my IV route, okay? All right, so now let's talk about, we already did all of that. Let's talk about sublingual and buccal. There is a couple of sublingual questions. I want to mention buccal, but I don't hear too many students tell me that they have questions about buccal. So sublingual is under the tongue. Okay, I'm gonna come back, and buccal is on the side of the cheek, okay? So you see here how there's a lot of veins underneath your tongue. So sublingually, medications get into your system quickly, okay? So let's go over the difference between the time of breakdown of the medication with sublingual versus buccal, okay? So buccal on the side of the cheek, those medication takes like 4 hours to disintegrate, to dissolve. Whereas sublingually, with all this lovely blood vessels under your tongue, 2 to 3 minutes, 2 minutes. Okay, a great example, nitroglycerin. Okay, somebody's having chest pain, you put that nitroglycerin under the tongue, within 2 minutes, it's in their system. You wait 5 minutes, if they're still in pain, you give another dose, right? So sublingually gets in your system, wow, 2 minutes, okay? So that's the difference between the two. NCLEX question. You cannot give clients sublingual medication or buccal medication and have them eat or drink anything. So during that time frame, if they eat or drink something, you didn't give it sublingually, it is now orally. And I'm hoping that makes sense. So teaching, please don't drink anything. Please don't eat anything. If not, you didn't give it sublingually, okay? All right, let's move on to another route, the patches. So a couple of things with the patches, and this is a select all that apply, so please pay attention. So with the patches, I love this little mnemonic because it kind of tells you all the do's and don'ts, okay, of patches. You're always wearing gloves, by the way. When you're taking off old one, putting new ones, you never do these things without donning on your glove. So you want to clean the area. First of all, let's go back. always don glove, remove the old ones. As you see here in the second picture, I mean, that is just crazy to just keep adding patch, but that's just common sense. Let me point out the stuff to you that is not common sense. So you're gonna don gloves, take off the old one, get rid of that glove, put on new gloves, put the new one, but don't forget, tell the client, okay, you cannot put heat in that area. And you also don't want them shaving before you put that patch, or don't put it in an area where they've shaved, okay, because then the drug get into their system a lot quicker than you intended, okay? And we don't want it in hairy areas, because then you'll be defeating the purpose. It will never get into the tissue. So little do's and don'ts with patches, okay? Not a big deal. Let's talk about eye, medication instillment, and ear. A couple of NCLEX questions with these. Always gloves, okay? If I don't mention that, that's just go without saying. You always have on gloves when you're doing these things. Now, for eye medication instillment, you see that medication never allow the tip of the medication to touch the conjunctiva, especially if you're giving something for an infection. Because think about it, you will be transmitting that to the other eye if it wasn't already infected. And that is not good infection control. So never have the tip touch the conjunctiva. Number two, don't forget, you want to teach clients post eye drops to squeeze the inner canter of the eye right there. Okay? You're decreasing that systemic effect where, you know, they taste in the back of their throat. So just a little quick teaching, they need to squeeze right here. Okay, for a little while to decrease that from happening. Now, there's questions about you knowing how to remove crust and exudate for those, you know, who have eye infections and they have those conditions, and you need to teach them. Always use disposable. Okay, so like let's say you're using a 4x, always that word disposable has to be a part of that, because that's infection control. Okay, you cannot reuse that. So it must always be a disposable. That word needs to be there. Okay, so you wipe, throw away. Okay, throw away. And sometimes you get the question, we lost connection? I see somebody said just reconnected. Ooh. But I was fine though. So I don't think it's on my end. And someone says, I can't hear you anymore. Can everybody hear me? Are we good? Can I continue? Oh, let me know. Let me flip slides and see if it works. Okay, so yeah, I think it might have been that one individual. We're fine, because I'm looking at you here on another screen as a student, and everything is fine. Okay, so I'm going to continue. So sometimes you get questions where you're installing an ointment, you're installing, you know, your drops, you want to do your drops, your ointment in that order. Don't forget to glove up, don't forget the inner canter, and they need to, you know, stay like that. You don't want to put medication and have the patient blink, 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 and wipe it away, because then you're defeating the purpose, especially if you're putting things like glaucoma medication or something like that. You want it getting in there. Here with the ear. So now a couple of things with the ear. This one is a special one, and let me tell you why. So when you're instilling ear medication, there's an age thing with this one. Some of you already know that. But don't miss that question. It's a silly one. There's an age thing with this one. So the cutoff for the age thing is 3 years old. So 3 years old and younger, okay, you want to pull the peen of the ear back and down. 3 years old and younger, down. Why? Because you're straightening, because the children, their ears at that age curves a little bit. You want to straighten. That's why. Older than 3, back and up. It's easy to remember. Older up, younger down. Okay, but the cutoff is 3 years old. Okay, so silly question, don't miss it. But same analogy earlier, don't unglove, don't let the tip of the medication, you know, touch the inner ear. And that person needs to stay like that for a good 10 minutes. I don't think they question you on that, but the age thing, yes. Nares, for this one, make sure, especially if you're dealing with children, make sure it's patent. Same thing with the ear. The elderly, make sure there's no wax, silly little things like that you already knew. But like the tip of the medicine shouldn't touch in the inner ear of this client, okay? And you see the gloves. I love these pictures because they have the gloves and they need to remain like this for a little while. Okay, couple of things with rectal. So rectal has a positioning question, and rectal is also a skill question on how to properly, administer like an enema or something like that. So rectal, I told you earlier, has a little first pass effect with the liver, but not like by mouth does. This is a great route for those who are nauseous and vomiting. This is a great route for those who are unconscious. We do this for children too. They don't want to take it by mouth, they're crying, all of that. So great route, okay? So a couple of things with this one. So number one, always glove up. Number two, always lubricate, okay? Because you don't want to damage tissue, always lubricate, okay? Number three, the positioning is left lateral because of the way your GI, is set, our anatomy. Left lateral, and there's one more thing I need you to remember. Teach the client to not defecate, okay? So for at least, 30 to 60 minutes, because think about it. I give you a rectal suppository and you have a bowel movement. It's gonna come right out, okay? So I need you to retain that medication for a good 30 minutes. So please, no defecating, at least an hour, like hold it in, because we need it to dissolve and get into your system. We have a lot of blood vessels too. Oh, one more thing with rectal. Don't forget, go past the anal sphincter. Okay, so there's a sphincter. Go past that. If not, your medication will come right back out. So go past that. Okay, so a couple of things. Glove up, lubricate, left lateral, go past the anal sphincter, and teach the client, do not defecate for me for at least an hour, okay? Because if not, the medication comes right out. So, and this is a skill, okay? Step one, step two, step three, okay. All right, inhaled beds. Let me make sure you don't have any questions. I can hear you. Okay, somebody says repeat ear. Okay, so let's repeat the ear because somebody says repeat the ear. So with the ear installation, there's an age madness with this one. So you have to remember the 3-year-old cutoff. So 3 years old and younger, you pull the pinna, right here in the ear. Back and down. 3, younger, down. Older, so if your question has a 4-year-old, a teenager, an adult, as long as they're older than 3, you're gonna pull back and up. Why? Because you're straightening out, for the little ones anyway, you're straightening out the curve, okay, so that the medication can go through. With that question, that's why I love when you ask questions, because it brings other stuff to my mind. NCLEX never gives you age without a purpose. That's what we call a biographical data. If NCLEX comes out and tell you it's a 2-year-old, it's a 17-year-old, it's a 65-year-old, or sometimes what they'll do too, they will give you the developmental stage. So be able to, number one, go back and forth, because you may know a 3-year-old, but you don't know a toddler. That's the same thing, okay? You may know a school age and not know that, you know what I'm saying? So you gotta be able to go back and forth. I do that when I do growth and development, but sometimes they'll give you the age and sometimes they'll give you the developmental stage, okay? That's still a biographical data. If it doesn't matter, the age, they will just say you have a client, okay? So if NCLEX goes out of their way and give you the biographical data, age of a client, wake up, okay? They don't just give you that type of information for no reason. Just while I'm on the topic, other biographical data includes occupation, okay? It also includes culture. If I go out of my way to tell you it's a Caucasian versus an African American versus a Hispanic versus, you see what I'm saying? There's a reason for me saying that. Okay, so that's what we call biographical data. So please do ask questions, because when you ask questions, other stuff comes to my mind. So that came to my mind from the person asking about the age. Someone says, are you getting my message? Is it via text? Because I'm getting all the messages on here. Miss Mark, let me see if I have anything else from you. Ask it again. If I missed the question, my apologies, ask it again. Let's go over inhaled now. So, and by the way, if you have any issues on the top part of your screen, you should have a little thing that says reconnect. Just press reconnect, because if your internet is acting up, it will reconnect you once you press that. Okay, inhaled. So this is another question that is utilized as a skill question. So they ask you what are the steps, you know, to teaching somebody to utilize a meter dose inhaler or spacer or something like that, where you have to drag and paste step 1, step 2, step 3, like that, right? So with this one, I have a couple of different ways I show it to you. I even have, these are pictures of the spacers and the inhalers. I even have the, you know, step 1, step 2, even with the clock to remind you. So let's go over that. So you want to shake the canister. Some clients are not able to do the 1 to 2, you know, or 1/2 to 2 inches to the mouth, so they can wrap their mouth around it. Okay, some children or some elderly can't do that. That's fine. Wrap your lips around it. Okay, so they breathe normally. Okay, have them breathe normally. And then the next breath, when they're inhaling, they need to dispense at the same time. So you're gonna dispense and take a nice little deep breath. Here's the part you need to not forget for NCLEX. They need to hold it. How long do they hold it for? 10 seconds. Why? Okay, I have a thing with the why, because why helps you build critical thinking. When you do my NCLEX test taking strategies, why is always a part of it. Why? We need those, you know, little crystallized, because, you know, when you're crushing a pill, you're breaking, you're making it powder. We need that to get into the alveoli. Okay, so if somebody is having like bronchoconstriction, or we needed to get all the way to the alveoli, you need to slow breath and then hold it for 10 seconds. If you don't hold it, then we probably won't get all the medication in there. So that's a key. And the little clock reminds you, because a lot of you are visual learners. By the way, you do need to know what type of learner you are. Okay, a lot of you are visual learners and you need to see it. Hence why I use a lot of pictures when I teach. For eye installation, please, what did you mention that should be disposable? Oh, okay, so like a gauze, 4x4, like the little gauze that you use, or if you use a cotton ball, whatever it is, it has to be disposable. The gauze are better because the cotton balls leave behind, you know, the little leftovers. So the 4x4 gauze are better, but they have to be disposable. Great question, because think about it. If it's reusable, ew, you're just gonna infect the other eye. So that's an infection control question. Okay, not really a pharmacology question. That's an infection control question, but it has to be disposable. Great question. Okay, so now nebulizer, same thing. You know, little kids, the younger they are, the harder this is for them to do. So we use the face, you know, shield for them. That's fine. However, we get it in the alveoli. All right, now let's go over. Thanks. You're welcome. Let's go over intravenous. Okay, IV. So with your not IV, with your parenteral, so we're gonna do IV in a moment, but I think I have my IM stuff before the IV stuff. I moved it around a little bit. Great route, they really are, but there are some little craziness you need to know about each route. And I'm surprised to know, because I just talked to a couple students recently who just passed. They're asking about the ventrogluteal and the dorsogluteal. I haven't heard that in a while, and I wonder why, but I do teach that, so I'm not worried. But I wonder why they brought that back. Okay, so parenteral drugs. Remember we talked about the liver and the first pass effect? This does not have the first pass effect. It doesn't go through the liver. Okay, it goes right into your veins, good and bad. It's great in an emergency because we get the drug flowing through your bloodstream like that, right? We put it right in there. Bad if it's the wrong drug. That is why whenever you're giving a drug intravenously, especially, and it has an antidote, you need the antidote at the bedside. And I have a list for you under my pharmacology section when you do the full review of NCLEX antidote. Tell me they can't get in phone. or we're doing the parenteral routes. We were talking about intravenous, good and bad. It's great, IV, you know, if there's an emergency, we get it right into the client's bloodstream, but it's bad if you're giving the wrong drug. So every medication that you're giving intravenously that has an antidote, every medication that has an antidote, the antidote needs to be at the bedside. And I have a document for you that says medication antidotes. You have to spend time with that because we don't know which one. We know which ones are most common, but we don't know which one they're gonna ask you on the NCLEX. So you kind of need to be familiar with at least the most common ones, okay? The other thing you need to remember when we're giving medication intravenously, IV, you need to know about your gauges. So just a quick refresher. Don't forget, the smaller the gauge, right, the larger the needle, and vice versa, okay? The larger the gauge, the smaller the needle. So depending on the size of the individual, okay, how chunky they are, how skinny they are, you're going to change your needle. But don't forget, if you're giving blood, you need at least a minimum of an 18 gauge, okay, for blood administration. I have to remind you, you need to work on and remember your layers of your skin, okay? Some medications you are asked, you know, the route you give it, is it sub-Q, is it intradermal, is it intrathecal? So you do need, like in this picture here, epidermis, dermis, sub-Q muscle, it's all, you know, different. So every medication is given a different route. We know insulin, we do sub-Q, okay, which obviously is the third layer. So you got to spend a little bit of time on this. In addition to it, you do need to know the angles, but those are not heavy material. Let's get into some heavy stuff, okay? So this is a list for you of the different routes and which medication and example that's given via that route. That's stuff you can read and memorize. So now I want to go over NCLEX stuff. So with sub-Q medications, those aren't, you know, a big deal as far as NCLEX. You do need to spend time with what type of meds are giving sub-Q, but don't forget we have implants sub-Q, you know, with the insulin implants, little things like that, but nothing major. We do 45, some books will tell you 90 degrees. They won't, you get too many questions on that because they go interchangeably. It's a preference thing. There's quite a few things to know in IM. So everybody wake up for me for a moment. So you need to know a little craziness about the ventral gluteal. You may very well get that question. There's a little craziness you need to know about the dorsal gluteal, vastus lateralis for the little ones, and deltoid. So we're gonna go over those intramuscular routes, okay? Let's do the deltoid first. I'm looking at your text. No, it's not the first 10 people, it's the 10th person. All right, let's do the deltoid first. What's the big deal with the deltoid? Not too much. The thing with the deltoid, right here, right? Let me show you a picture. It's a very small muscle, okay? So because it's a very small muscle, maximum, where's my deltoid picture? I have one. Maximum, right here. Maximum you can give via the deltoid is 1 ml. So silly little question, you won't get that wrong, okay? And again, if you see the picture, it's a tiny little muscle. So you don't want to give more than 1 ml in the deltoid. You know, that's really all you need to remember in that one. Nothing heavy, nothing complicated with that one. Okay. In general, though, we're going to get to the bigger muscles. In general, you always want to aspirate with the intramuscular. I know, like, some facilities in some places have changed their policy and procedure and rules with that, but NCLEX, we're still aspirating, folks, okay? You need to pull back. When you pull back, if you see blood, you're not in the muscle, okay? You're in a blood vessel. So you have to get out and you need to discard, throw away that needle, that syringe, everything. Because had you given that medication, you would not have given it intramuscularly. Okay, when you pull back, you get blood, you're not in the muscle, you can't give that drug. You have to get out, throw away everything. You start over. So we aspirate to make sure that we are in a muscle. You get no blood back, you're in a muscle. Then you can give your medication. Okay, so one more time. For intramuscular medications, we do still aspirate because students have asked me that because some places, you know, change their routine. For NCLEX purposes, you're aspirating, and if you get blood, get out. Throw away everything. You're not in a muscle, okay? You're in a blood vessel. And we do our IMs 90-degree angle, not 45, 90-degree angle. All right, so let's go over those other IM routes and then what's so special about them, right? You see this picture right here before we move forward? That, I don't think you can see my cursor, but right, that needle that's 90 degrees, you see how we're passing a blood vessel? So this needle is in the muscle, but if you were to aspirate and you get blood back, it would be in the blood vessel. So I wish I could get this picture in color. I've been looking for it in color, but I haven't found it in color, but it's a very nice picture to show you the blood vessel in the muscle, okay? So now let's go over these other muscles and what's so special about them. First, let's do the ventrogluteal. So imagine this picture. This is a client who's supine, right? Who's on their back. You're going to take your non-dominant hand, you're going to put it at what we call the greater trochanter. So you see the picture here of the femur bone. The very top of the femur bone is the greater trochanter. Your palm, the palm of your hand, goes right there. What are we doing? We're looking for the perfect ventrogluteal muscle, okay? So you put the palm of your hand there, and then you open your pointing finger and your middle finger, like in the picture here, literally open them. The middle of those two fingers is where your ventrogluteal is, and that is where you inject if you're going to use the ventrogluteal muscle. That is the only one you look for this way. So if I'm describing something like that, you know what muscle I'm going to use, okay? Because we don't do that for the dorsogluteal. We don't do that for the deltoid. Like, we don't use that modality I just taught you to find the muscle. We only do this with the ventrogluteal, okay? So put the palm of your hand at the greater trochanter, and then open your pointing and your middle finger. The middle in between your pointing and your middle finger is where your ventrogluteal is. Now, I wouldn't be surprised if this is a hot spot, okay? So know about this and know why we're doing it. We're looking for that perfect IM injection site. Now, there's something special about the dorsogluteal as well, okay? So the dorsogluteal is that muscle that is in the upper outer buttocks, upper outer buttocks. So you see in this picture here, stay away from that central, okay, middle portion of the buttocks. By the way, the root word door is back. That's why this is dorsogluteal, the words. I'm good at breaking words down. I'm good at prefixes, suffixes, and root words. That's why I like to break words down for you. But take the client's buttocks and do a, like in the picture here, do a plus sign, okay? And then you have these 4 boxes. You wanna go in the upper outer one, okay? Why, okay? You know me and the why. We have to go over the why. I have to tell you why, because that's number one, that helps in your long-term memory when you know why you're doing it, and that helps with critical thinking. You are avoiding the sciatic nerve. That is why you need to find this muscle, you know, with the plus sign, and remember upper outer. So you are avoiding the sciatic nerve. If you inject a client in the sciatic nerve, you could paralyze them, okay? So that's a safety one. So, okay, they test you to know that you know how to find it, and why are you doing that? You're avoiding that sciatic nerve. It's a huge, huge nerve that goes through the pelvic bone, like in the picture here. It's really big. So you really want to avoid it when you're giving this any injection, and plus avoid dorsogluteal if you can in general because of that purpose, okay? Oh, somebody says, I thank you for the why. You're welcome. Yes, always when you're doing questions too, even if you get to the correct answer, ask yourself why? Why? Because you may get another question that it really is testing that you know why, because that's the critical thinking portion of it. Now, the not the dorsogluteal, vastus lateralis, like in my little baby picture here, we use the vastus lateralis with the little ones until they're walking. You know, after they're walking, we can use the ventrogluteal for them. Now, don't forget, sometimes they give you the picture of this baby and they ask you, you know, left versus right. So just make sure you get it right with the left versus right type of question. But that's the vastus lateralis for the little ones. We use that until they're walking, okay? Once they're walking, we could use the other muscles. Z-track. So Z-track is a skill question, okay? You're gonna drag and paste step 1, step 2, step 3, step 4, like that. But what is the purpose of Z-track? Why do we do it? And how do we do it, okay? So we do Z-tracks for a couple of reasons. We use Z-track method for medications that are like Depo-Provera. They release in your system little by little by little for months. And we use Z-track for any medication that's going to stain the skin, like iron. We want to use, you know, this modality for that purpose, to avoid that purpose, okay? Now, let's start from the beginning. Let's say you're going to administer iron to this client. The needle you're using to draw the medication is not the needle you're going to use to inject the medication. Okay, so silly little question. So you use one needle to, you know, pull back the medication, and then you want to discard that. Okay, you're going to put a different needle to inject. Okay, because think about it. If you use the same needle to pull the medication to inject, you're staining the skin. And we want to do this via Z-track to avoid staining the client's skin. All right, so I need to find a picture of a stained skin so that, you know, you get the visual. So we're going to draw up our medication, change our needle. Oh, by the way, another NCLEX question with changing the needle. Whenever you use vial, medication from a vial, you know how we have to break the tip of the glass vials? You got to change needles. Because think about it, there could be little fragments, little glass fragments in the drug itself. So you always want to use a filter needle to draw out of a, you know, a glass vial, and then you change that needle to the needle you're going to utilize to inject the client. So this is another NCLEX question where you need to change your needle, and it makes sense. You don't want to instill glass into the patient. All right, so back to Z-track. We want to use a large muscle, obviously, and we want to use the ventral versus the dorsal. We avoid the sciatic nerve. So we're going to pull the skin back. Literally, you're like, Todd, you're pulling that client's skin back, okay, as much as you can. You're going to inject your medication, okay? You're holding the skin back. You're injecting your medication, okay? You want to allow your needle to stay in there for a good 10 seconds, okay, after you inject. Now, this is the tricky part. You pull out and you let go of the skin real quick. Those of you who are visual learners, let me show you. When you pull out, you gotta let go of the skin. That's the Z-track. You are sealing, okay, where that medication normally would come out. Because if you didn't pull back, the skin is still, you know, leveled, layered. But because you pulled back, and then that pathway you made, once you come out, you wanna seal it. Okay, so that the drug doesn't seep out, doesn't come out and stain the client's skin. So that's your Z-track format, okay? And again, we use them for a couple of reasons. Your Depo type of drugs, like we use with schizo and iron, great way to do this, okay? Okay, now intravascular. So we can do drugs intravascularly, intra-arterially. I saw earlier somebody says, can I go over arterial blood gas? I thought I saw that earlier. Okay, ABGs. I do arterial blood gas when I cover respiratory, because it makes sense there, because, you know, that's when we go over all the COPDs and all of that. So I cover that under the full-blown review, and I have a very specific way of helping you figure out whether they're metabolic acidosis, alkalosis, but that's not something that I can do in just a few minutes. It's the nature of that beast is a little complex, okay? But I do teach ABGs, of course. I don't know where I saw that, but I saw that earlier. And forgive me if I missed your question, ask it again, okay? If I didn't answer it. Okay, let's go to intravenous and intra-arterial. So again, when you give these medication, it's in the client's system, and then plus, in addition to you making sure you have your antidote right then and there, if God forbid, you know, they're having an adverse reaction or it's the wrong drug, you also need to consider whenever you're giving something intravenously or intra-arterially, you're at risk of air embolism. Okay, because again, you're penetrating, there's a risk of air getting into that client. So you need to make sure you spike you know, everything, that there's no air bubbles, and that your IV dressing is tight. So all those things prevent. And then you have even like a lure lock to prevent. So there's a lot of things that we can do to prevent air from going, you know, into that client. So this is a nice, beautiful picture of a catheter going into a vein. I love it. I love when they're in color too. And I love using Atom. They have such beautiful pictures. Okay, so let's go over a few different intravenous modalities. Now, NCLEX out the wazoo, people, okay? So you have your PIC, peripherally inserted central catheter. So these are all central lines we're going to talk about, but your PIC starts peripherally. Great way of giving drugs, not a problem. You need to remember though, this can't be long-term. Okay, you're giving TPN for more than 7 days, it can't be VIP. Okay, you're gonna need a tunneled, non-tunneled, or port. Yeah, that can't be long-term, but that's a nice picture of that on the bottom here. Let me move this out of the way. That's a nice picture of a PIC to give you the visual. So peripherally inserted. By the way, pay attention to names, because names tell you a lot. Okay, peripherally inserted central catheter. So the name really tells you what the heck is happening. So you see how it starts peripherally, but it does end up in a central, okay? Like in my picture here, this is the bottom one. I'm going over the bottom one. In this picture here, it's ending up in the subclavian vein, nice large vessel. On the top left, that is a non-tunneled central, and on the top right, that is a port. I'm gonna go over those, okay? Did my thing stop working? Hang on. Okay, there we go. Okay, so now I love this picture too, because you're able to see peripherally, you're able to see the subclavian, you're able to see the superior vena cava. So I can have tunneled, means it's going under the skin and then into the great vessel. Non-tunneled goes right into, okay? So the words kind of tell you what's happening. So here's a picture of a non-tunneled, okay? And then I'm going to show you a picture of a tunneled. Where is it? There we go. So this is a tunneled, okay? Double lumen tunnel. So it goes under the skin, under the skin, under the skin, and then boom, into the large vessel. So now, why do we use these? Some of them, pros and cons, okay? So if you're using something long-term, you need a central line, okay? Short-term, not a problem. We can do peripherally. Let's differentiate. What's the big deal between a PIC, tunneled, non-tunneled, and a port, okay? NCLEX. The different types are Broviac, Hickman, Groshung. We like when they have the bevel that prevents air, okay? So let me do a couple of NCLEX things here, and then I'm gonna go over the different. If you take a look at this picture, so you have a tunnel, you see the catheter coming out of the client. Now, take a look at this one. What's the big difference between the two? Decreased risk of infection, NCLEX, okay? So your PIC, your tunneled, non-tunneled, you are more at risk of an infection than you are with a port, okay? They're all inserted surgically, so that part is common for all of them. But all of them, yeah, it's inserted surgically. But this one, so first of all, there's a nice open pathway for pathogen to just climb up and go wherever they please. And this one is a little bit more high maintenance versus the port. I'm gonna go over a port in a moment as well. So this, and your PIC, you need to be measuring on a regular. We don't want it going further in. We don't want it coming back out. And then with these, when we, discontinued them, we want to make sure that metal tip is still there. So there's a lot. Now for a PIC is even more high maintenance, because you want to measure the patient arm, make sure they're not having any type of edema. Okay. You want to make sure, you're following your dressing changes on a regular. For most places, it's every 7 days of PRN. Okay. Of course, if it's soiled, I'm going to do it, but we do the 7 day, and it's under, sterile technique. So that's high maintenance, right? We don't like high maintenance. You'll hear me mention that word all the time. We like low maintenance, okay? So recap, they're all surgically implanted. Your PIC, tunneled, non-tunneled, require dressing changes. They require regular measurement. They require, for you to use sterile technique. Okay, now let's talk about the port. The port is different. Number one, less risk of infection. Why? With the port, unlike your PIC, your tunnel, non-tunnel, this one we access and de-access. Okay, please, okay, I will. We access and de-access. So I used to do TPN, chemos a lot, like in home health, like I would go to the client's home, and a lot of them, the majority of them had ports. Sometimes they would have a double port right next to each other, and we would alternate which one we use. But I go to the home, okay, I have my sterile kit there, patient wears their mask, they turn their head, I wear my mask, it's all sterile procedure. But my point is I access and I de-access. So I access it, I give my medication, my TPN, my chemo, whatever it may be. We have a lot of children, the agency I used to work for, I was a director there. We have a lot of children who come from St. Jude for the summer, you know, locally. So we're responsible for their chemo and everything. So I access, I give my medication, and we access what you call a hover needle, okay, like in the picture here. So once I give my medication, I de-access and I'm done. There's no pathway for pathogen. There's no catheter hanging out, you know, to increase risk. So this is very low risk, you know, for infection. But all of them, don't forget, you have to flush, you have to heparinize. If not, they get clogged, okay? And we don't like that, because if it's severely, then they have to have surgery again to replace it. That's a pain in the butt, okay? So you always want to do that. Let me show you this chart. Is all of them next to each other. So if you look here, insertion procedure, okay? Sterile, bedside sterile, surgical, 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 dressing, sterile, sterile, sterile. Your port doesn't need one, obviously. Insertion site, subclavian, those are all, you know, major blood vessels. So I like to see things next to each other in my mind, because that's how I organize information in my head. So I like to, you'll see me do charts like that all the time, where I put things next to each other and organize it for you. Okay, so now let me do tunnel and non-tunneled real quick, because I see a question here about tunneled versus non-tunneled. So tunneled means it's going under the skin and then it goes into a great vessel. Non-tunneled, it goes right into the great vessel. That's the big difference between the two, but they both have the catheter hanging through. They're both put you at higher risk for infection than a port, okay? So that's the difference between those two. Tunneled, under the skin, non-tunneled, right into the great vessel, but they both end up in a great vessel, unlike the PIC, okay? Now, fluid. Fluid is special. This is one of those areas you have to focus for me, and you have to wrap your brain around it for me, because it's a heavy topic. We have to go over isotonic, hypotonic, hypertonic solution, okay? I could make a level 1 question out of this. I could make a level 4 question out of this. So this is one of those where you can complicate the heck out of it, or you could simplify it, okay? So I'm going to go slowly. And if you get, you know, this question, level 3, level 4, you're doing really well on the NCLEX, so you want to know this and process this, okay? So IV fluids, intravenous fluids. Why do we give them? Number 1, okay? We give fluid because we want to balance you. We give fluid because we want to replace fluid you've lost. We give fluid also to treat electrolyte imbalance, okay? We're going to talk about iso, hypo, and hypertonic solutions. So these are the reasons we may need to give you fluid, okay? Fluid balance, fluid replacement, or electrolyte imbalance, okay? So those are the reasons. Okay, someone says, drug calculations, please, and then Brovia, Hickman, and Grosjean. Okay. So this is what I'm going to do. With the drug calculation, I have a video where I teach it a different way from the dimensional analysis. This is the thing with drug calculation. I'm careful with that one because some of you already learn how to do it a certain way and you don't want to change now. Math is a special animal. You have to continue to do math the way you first learned it. It's because as we get older, it's not easy to undo that, to change that. So I have that video. I believe it's published on YouTube. Check it out. it's not the dimensional analysis. It's a different way. I do the step 1, step 2, step 3 to teach you how to do the drug calculation. But I'm not going to do drug calculation under this one because not everybody needs it, number 1, and not everybody should change the way they're doing it, number 2, because if you're doing the dimensional analysis, you love it, it works for you, don't change. I will never advise you to change with that, okay? But if it's not working for you, don't get it, the way I do it is another way of learning how to do it, but that's on YouTube. Okay, we're not gonna do that one today. I'm sorry. And I have something too under Brovia, Hickman, and Grosjean. The person that's asking for that, I have a little chart of all 3 of them next to each other and what the similarity and the difference are, which has Lurlock, which doesn't. Reach out to me and I'll send that to you. NCLEX is based on problem solving, critical thinking. Absolutely, but you may get, as a matter of fact, maybe last week sometime, I had a student call me and said, I kept getting, conversions, math questions. So don't underestimate that. Okay, yeah, don't underestimate that. I'd rather you be prepared and, be able to handle it if they throw it at you than for you to underestimate it and then you get, bombarded by it. Because again, we don't know what your questions are going to be. So we prepare for everything. We cover all client needs categories, or because some of you are sending me open chat, some of you are sending it private. So if you see me answering a question you don't see, is because somebody's sending it to me private, and that's okay, you can do that. But I enter it for everyone. NCLEX don't give you time for dimensional analysis. Too many steps. I would agree with that. Yeah. So that's why I do the step 1, step 2, step 3. The dimensional analysis takes a little bit longer. But if that works for you, don't change now. We're too old to change how we do math. There's some truth to that too. So I'm always like, yeah. So check out the video I have. If it helps, great. If not, reach out to me and I'll see what else I can do. And NCLEX is based on most nursing following how we go about this. I need a short way. Okay, I got you. All right, so back to fluids. I'm gonna do isotonic first, and then, I don't like this one, I like this one. And then I'm going to do hypo, and then I'm going to do hyper, okay? So let's do iso first. And why do I always start there? Because if you know isotonic, you know hypo, and you know hyper. Promise. So let's do iso. So what is isotonic solution? So isotonic solution is the same gradient, or approximately has the same amount of electrolyte as your blood. Okay, so similar. Okay, you need to know what fluid is similar, to blood. Like what fluid is considered isotonic. I'm going to come back to this in a moment, I promise. So the middle chart here is, refresh everybody. The middle chart here is isotonic. So isotonic is similar to plasma, right? We know that. And we know in our plasma, we have sodium, potassium, chloride, sugar. Yeah, we know that. So isotonic solution has the same osmotic pressure to blood to plasma. So what is that solution? Which solutions are isotonic? So that's where you need to, spend a moment, because it requires a little bit of memorization. So normal saline, AKA sodium chloride, is the same as plasma. So what is sodium chloride? Sodium chloride is 0.9% sodium chloride. It has water, of course. It has 154 MEQs, milliequivalent of sodium, and it also has chloride, hence the name, sodium chloride, also called normal saline, right? Same thing. That is isotonic. You've done questions where they tell you the patient is on lactated Ringer. That's isotonic. So lactated Ringer has sodium, it has potassium, it has calcium, and it has chloride, just like our plasma. Sometimes you'll see it as a capital L, capital R, same thing. Sometimes you'll see Ringer solution, same thing. Okay, so we use these interchangeably. Another one that's similar to plasma is D5W. 5% sugar, dextrose, and water. That's also isotonic. So you need to minimally, number one, step one, know what solutions are isotonic, like plasma. Okay. Tonic, same as plasma. That is 0.9% sodium chloride. Please remember the 0.9%. I'm going to tell you why in a moment. Same thing as normal saline, lactated ringers, D5W, capital L, capital R, ringers lactate, all the same. Okay, that's isotonic solution, same as plasma. It doesn't work. Oh, it worked for me. Yeah, it worked for me. So try the 3 little dots. Huh, that's odd. We'll have to figure out another solution why. Okay, so now let's do hypo. So under iso, I told you 0.9% sodium chloride, okay, is isotonic. So therefore, anything that has less osmotic pressure than that is hypo, less, below, lower than sign, down arrow. Okay, so any fluid solution that has less than 0.9%, okay, or less osmotic pressure, then isotonic is hypotonic solution. Okay, so on the left hand side, you see 2.5% dextrose in water. Yeah, that's less than the 5% we said was isotonic, so that makes it hypo. You see here 0.45% dextrose in water. I'm sorry, sodium chloride, 0.45. That's half of 0.9. So 0.45 sodium chloride is half of 0.9%. So if 0.9% was isotonic, and half of that will be hypo. Okay? So hypotonic solution has less osmotic pressure. So 2.5% dextrose in water, or 0.45% sodium chloride in water, all of those are hypo. So right now, don't worry about what they're used for. I'm going to go over that in a moment. We got to do things by step. So now let's go to hyper. So anything or any fluid solution that has a higher osmotic pressure than plasma is hypertonic solution. Okay, so on the middle side, isotonic, we said 0.9% sodium chloride was iso. Look on the right side, 3%, 5%, 5% in dextrose, 5% dextrose in 0.9. Those are all hyper. Okay, 5% dextrose in lactated ringer, hyper. 10% dextrose in water, hyper. 20% dextrose in hyper. 10% hyper. 3% sodium chloride, hyper. Because iso, okay, was 0.9%. You've got 3%. Okay. TPN, of course, hyper. Full pack red blood, albumin, hyper. Okay. So now you get iso, you get hypo, you get hyper. Okay, so now we have to complicate it just a little bit. Sorry, I always start, and then I have to. So we need to know, who do we give what fluid to? Okay, so, but some of you are visual learners. Let me show you something. Those of you who are visual learners. So we're gonna do this visually. Iso is the one on the top left, okay? So focus there for me for a moment. Isotonic, reconnect so you can see my picture, and then hit your 3 little dots. Iso, you see where it says amount of water transported into the cells equal the amount of water transported out of the cell. Whenever you give isotonic solution, the exchange that happens is equal. It doesn't shrink the cell. It doesn't fatten the cell. What goes in comes out. Okay? Solid concentration inside the cell is equal to solid concentration outside the cell, because isotonic solution is the same thing as what's going on in the cell. It equals the same. So it doesn't pull it, like there's no tug of war, because it's equal. The osmotic pressure is equal. Okay? So that's isotonic. Now go down. You see where it says hypotonic solution? So whenever you give hypotonic hypotonic solution, you will fatten up that cell. So whichever one is more concentrated, the cell versus the fluid you're giving, whichever one is more concentrated, it's gonna pull from the other, okay? So with hypotonic solution, the cell, okay, the vacuoles inside the client, the patient, is more concentrated. So it's gonna pull that fluid, that hypotonic fluid that you gave. So it's gonna fatten up that cell, okay? So when you give hypotonic solution, the cell pulls that fluid and it fattens it up. So you want to give hypotonic solutions to dehydrated clients, to your diabetic ketoacidosis client. I'm hoping that makes sense. Okay, now let's do hyper. So again, whichever one is more concentrated will pull the other. So when you give hypertonic solution to a client, that solution is more concentrated in the client's cell, okay? So that solution pulls fluid out of the cell and it will shrink the cell, like you see on the top right-hand corner. So when you give hypertonic solution, it pulls it out of the cell. So those are great for your burn patient when they're at that edema phase and we need them to, all that fluid to leave. We want to give some hypertonic solution so it will, and then they can urinate it out. Hopefully they don't have any renal problems. Okay. Somebody says, how is 2% dextrose less? Where are you? Okay, so you see isotonic was D5W, 5% dextrose in water. Now, if you're doing half of that, 2.5 is half of that, that's hypo. Okay, that's hypotonic solution. Let me repeat that so I can make sure it makes sense, so then I'll move forward. So the question is, why is 2.5% dextrose in water less than hypo? Because iso is D5W. So 5% dextrose in water is iso. So 2.5, which is half of that, is hypo. Okay. So then, you know, when we give isotonic, what goes in comes out, it's equal to each other. It doesn't shrink or fatten the cell. When you give iso, when you give sodium chloride, when you give normal saline, lactated vinegar, D5W, nothing happens to the cell. Okay. When you give hypotonic solution, that will fatten the cell. So hypotonic fluids are used to treat conditions that causes intracellular dehydration. Because remember, when you give hypotonic solution, the cell is more concentrated and it's gonna get fat. So you want to give hypotonic solution to dehydrated clients. Your diabetic ketoacidosis client, they are dehydrated. Remember the polys? They're eating a lot, drinking a lot, going to the bathroom a lot. Yep, they're dehydrated. Okay, so you want to give them hypotonic solutions. Okay, and you want to give the hyperosmolar, hyperglycemic state. Those are those clients who aren't a diabetic, but they act like they're diabetic with their blood sugar rising, but they don't have the ketones. So you want to give them hypotonic solution. Okay, so now let's go to hyper. So when you give hypertonic solution, that fluid is concentrated, higher concentration in the cell. So it's gonna shrink the cell, it's gonna pull from the cell. So whichever one is more concentrated will pull the other. It's like a magnet, okay? So hypertonic fluids are used as what we call volume expanders, okay, for the conditions like, for example, anybody with electrolyte deficiency, like you have a hypokalemic, hyponatremic, okay, you can add as much electrolyte in those fluid as you want, which makes it hypertonic solution for those clients. And also clients with cerebral edema, okay, let's say they get into a car accident, some type of trauma, and their brains are swelling up, you want to give them hypertonic solution and pull that fluid out. And if their kidneys are working beautifully, they'll urinate it out. Awesome stuff. And don't forget TPN, of course, these are very concentrated. You figured those. Okay, somebody says, I got it now. Awesome. All right, any questions with fluid, okay? If not, I'm going to go to TPN, Okay, these are just different routes. Oh no, there's one more thing I want to cover before TPN. Remember peak and trough? A student recently had peak and trough, so I got to go over peak and trough. What time is it? Ugh. Hang in there, people. Don't leave. I want to go over peak and trough, okay? Because a couple of students recently had peak and trough, and then we'll do TPN. Just a couple of things with TPN. Well, yeah, don't go. All right, peak and trough. So every drug has what we call an onset. Let me show you this picture. Yeah. Has what we call an onset, right? It starts to work, okay? Every drug has a peak. A peak is when the drug is working at its maximum. Every drug wears off. Every drug, okay? It's got to get out of your system. What goes in has to come out. What patient would you give ISO to? Okay, so ISO would be just if I want to give you free fluid. Okay, I'm not trying to replace, you're not dehydrated. I'm not trying to remove fluid. So just to keep you, hydrated. If you're PO, you're not taking any fluid by mouth. I want to give isotonic so you don't end up dehydrated on me. But so that's something you'll hear we say free fluid. So that's isotonic solution. Great question. I'm staying until the end. Yay! Awesome. Okay, so peak and trough. So this one is on the NCLEX, so make sure you get it. Remember earlier we talked about you having 30 minutes, to give your medication. So here's another category you could put the whole 30-minute thing under. So you give a drug. Most drugs start to work immediately, especially if you're giving it IV. We're gonna. I'm not covering insulin here, but insulin is such a great example. Like regular insulin IV starts working in 10 minutes, okay? So every drug has a different onset time, but you give the drug, onset, it starts to work, right? Every drug also has a different peak time. Some drugs, take half an hour, but this question deals with vancomycin, and the real NCLEX, for some reason they like vancomycin. So you give the drug, about half an hour to an hour, it's at its peak, okay? Meaning it's working at its maximum. And then it wears off in your system. So the question asks you, when do you draw the patient's blood to find out the peak of the medication, when is the medication? And then physician will also ask you to do a trough, to pull the patient's blood again, to do blood work again, to see when is the medication wearing off. Why do they do that? We got to do the why. Sometimes drugs need to be adjusted, okay? So sometimes frequency needs to change, okay? So depending on what the results are, the physician may order the drug to be giving more frequently, or they could spread it. It depends on what's happening. I like to use Mrs. Jones. What's happening with your client, Mrs. Jones? So physician will say, okay, pull a peak and trough on the third dose of, the vancomycin. So let's say, by the way, if they're asking you this question, like the peak and trough, they have to tell you how frequently the client is on this drug. So let's say they're on vancomycin every 4 hours. Okay, I'm making this up as I go. So they're on vancomycin every 4 hours, and the next dose is due at noon. Okay, so you're gonna give your vanco at noon. Within half an hour, your peak is going to take place. So you're gonna draw your peak 30 minutes after you give the drug. Okay, so if I'm giving it at 12, I'm going to draw my blood work for my peak at 12:30. Now, I told you Mrs. Jones is on vancomycin every 4 hours. Okay, so the vancomycin is going to be due again at 4 p.m. Right? So when do you do your trough? Your trough is done 30 minutes before your next dose. So if Mrs. Jones' vanco is due again at 4 p.m., I need to draw my trough, pull that blood work again at 3:30. I'm going to give you a different example so I can make sure you get it. Okay. After you send the link to everyone, please. Okay. Webinar Jam works like the link that I sent you that you got on. That's good for a while. It repeats again, but I'm going to transfer this to a YouTube, so you'll get it on the YouTube, okay? 3:30, yes. So let me give you a different example to make sure you get it. So your peak is done 30 minutes after you give your dose. Your trough is done 30 minutes before your next dose. So here's your NCLEX question. Mrs. Jones is on vancomycin, okay? And it's every 6 hours. And your next dose is at 3 p.m. So when do you do your peak and when do you do your trough? So Mrs. Jones is on Vinco, and I want you to do your peak and trough with the next dose. And your next dose is due at 3 p.m. and she's on it every 6 hours. So when do you do your peak and when do you do your trough? It's due at 3 p.m. and it's every 6 hours. Are the same PowerPoint as the one from resources from. There's a little bit of update on this PowerPoint from my resources. So, but for the most part, yes. But I did update some things. Yes, you do. No, you do your peak at 3:30. Okay, I see some answers coming through. Your peak is done at 3:30, okay, because you're gonna give your Vinco at 3. You're gonna do your peak 30 minutes later, 3:30, and it's due again at 9 p.m. So because it's due again at 9 p.m., when will you do your trough? 3:30, yes, that's for the peak. 8:30 for the trough. Yay! Awesome. Okay, so that's peak and trough, okay? And every drug has onset, every drug has peak, that's when it's at its strongest. There's a nice NCLEX question right there. Let me tell it to you just in case you get it on your real exam. Whenever you're giving pain medication, okay, which two has a peak, do your procedures for your clients that are painful when the drug is at its peak, okay? That's just a very nice ethical thing to do. So you give your morphine, okay? You wanna do that dressing change, okay? Whatever it is that's painful for the client, have them do it when the pain medication is at its peak, okay? Because less pain, okay, that's just nice. That's a silly NCLEX question. Somebody says, I'm yet to get it, please. You want me to repeat? Okay, so let's go over it one more time. So whenever a physician orders a peak and trough, you want to do your peak 30 minutes after you give the drug. And you want to do your trough 30 minutes before the next dose is due. Because the peak tells me, you know, when is the drug at its peak, like at that time, you know, when you pull it, and then the trough tells me, is it wearing off? Okay, because remember, we want the drug in the patient's system as long as possible so it can do, you know, what it needs to do, but at a therapeutic level, of course. Okay. All right, so let's go to TPN. So TPN is special. All right. First of all, always a central line. If you're doing it via a PIC, it has to be short term. Okay. So let's talk about what is total parenteral nutrition. What is it made up of? Okay, what's in that lovely bag? The majority of what's in a TPN bag is sugar. Why do you need to know that? Because think about it. Let's say you have a client who's on TPN the majority of the day, or some clients are on it, you know, 24-hour TPN madness. You need to know that literally this client is getting in, you know, intravenous sugar. That's a lot of sugar all the time. So you have to keep that in mind, okay? So they are at risk of, okay, hyperglycemia. So naturally, with a client on TPN, we have a sliding scale. We are to do their AccuCheck on a regular, like it just goes, you know, because of what's in the bag, okay, because of the content of what we're administering. So for sure, you're doing that AccuCheck. Most physicians will give you a sliding scale. If Mrs. Jones' blood sugar is between 250 and 300, give 2 units of blah, blah, blah. So yeah, automatically, okay? Why do you need to know though about the whole content? I'm going to come back to this in a moment, NCLEX. The reason is there's an NCLEX question that tells you you no longer have your next bag of TPN. Like literally for some reason, you can't get your next bag to hang. So Mrs. Jones is going to be cold turkey, okay, off of her TPN, which is very dangerous. We never cold turkey anyone from anything, by the way. we'll abruptly stop something if you're having an anaphylactic reaction, okay, like a severe, reaction. Yeah, other than that, we always taper down. Because whenever you cold turkey somebody off of something, the body tries to compensate. Think about it. I've been on this medication for however long, all of a sudden nothing. No, you've got to gradually take them down. So now imagine you can't get your next bag of TPN. That is cold turkey somebody. You need to hang sugar. That's the answer to that NCLEX question. Hang 10% dextrose if TPN is interrupted. Okay, you can't abruptly stop TPN like that. You've got to taper. If they were on it 24 hours, then we move them to 18 hours, then we do 16 hours, then we do, and then we take them off. You can't just, that's just terrible. Okay, so you know why we need to know what it's made up of, okay? You don't abruptly. So let's talk about some of the other complications. So, hyperglycemia, because it's all the sugar, acidosis, because they might go, the blood sugar may go well over 500, 600, crazy. And they're also at risk of an infection because we're talking central line. Whenever we're talking central line, you're at risk for that. Even with the port UR, it's not as much if you have a tunnel, non-tunnel, or PIC, but you're still at risk for infection because you're, bloodstream. Anytime you're hitting the bloodstream, there's a risk of that. And you're at risk of air emboli. Okay, make sure you're using products that have a lower lock. It prevents it. Make sure you're spiking your tube. Make sure your dressing is, well occluded. So all of that prevents it. But let's say your client is having air emboli, you have to teach them to Valsalva, like bear down to undo that damage. Okay, so if they start with that shortness of breath and all that madness, teach them, bear down for me until we can figure this out. All right, so a couple more things with TPN. Let me go back right there. I told you I'm going to come back to this slide. TPN is always on a pump. Those of you who have taken my test taking strategy course that I do for free, there are these words called absolute. Always, forever, never, every, all. Those are what we call absolute. Be very cautious of them. But there are exceptions to the rule. So think about it. Life is not all, always, forever, every, like till infinity and beyond. Like life is not like that. That's what we call absolute. So those are rare, okay? But there are exceptions. And I always point those out to you because they shouldn't, be throwing you off. But be careful when you see absolutes, okay? So TPN, blood, right? They are always on a pump. You can't free run things like that, okay? Pitocin, oxytocin, always on a pump, okay? Magnesium, always, because those are things that we titrate, okay? Because we up and down them depending on what the patient's, status is. So they are always on a pump. So if you hear me just say that, yes, that is an absolute, that is true. Only regular insulin is given IV. That's true. That's an absolute, but it is true. Okay. So be careful of absolutes, but there are exceptions. Okay. And we always have our normal saline piggybacking. Okay. Just go with that state. So that's an NCLEX question. Always on a pump. Okay. And we titrate based on what the patient is doing. So you're at risk of hyperglycemia. You know why. And protocol, you and TPN, we're going to pull your BUN, your creatinine. We're going to do your AccuCheck. We're going to pull your electrolytes. It's just protocol. Doesn't matter what hospital you work at. Okay. All right. Now let's do blood. Somebody wanted to know about the test taking strategy. It's on YouTube. So put Darlene Riggs or put Be the Drop. Be the Drop is my nonprofit. So it's under that YouTube channel and it's there. I think I called it test taking strategies or free review or something like that. But you'll see other videos too. Thanks. You're welcome. Okay. Oh, please repeat absolutes. Not a problem. So absolutes are words that are definite. All, every, forever. Those are words that are like, oh, so be careful when you see them, especially if they're part of the answers, because they usually make that answer incorrect. Life is more like sometimes, maybe, not all, every, forever. So, but there are exceptions, okay? And the ones I just mentioned with the TPN is always on a pump. You never free run that. Blood is always on a pump. Magnesium is always on a pump. Pitocin, oxytocin is always on a pump. There are a few more. So there are exceptions to that rule. But whenever you see absolute, always, all, every, a little light bulb needs to come on, okay? Because life is not like that. So be cautious of absolutes. Can you name the YouTube? Yes. So my name will pull it up, Darlene Riggs, Darlene with an I, Riggs, or Be the Drop, B-E, the T-H-E, drop, T-R, D-R-O-P, Be the Drop, okay? So that's the YouTube channel. Okay, awesome. So now let's go to blood. So, you know, we type screen, folks, especially if we're gonna give blood, you got to. Are you A? Are you B? Are you AB? Or are you O? While we're there, let's go over who's a true universal donor, who's a true universal recipient, okay? Your true universal donors are your O negative, okay? Because remember, negative can give to, but positive cannot give to negative, okay? So your true universal donors are O negative, okay? Your true universal receivers are your AB positive. They really can get anybody's blood. Like A positive, negative, B positive, negative, AB, yep. So if you're AB positive, good for you. Kudos. If you're O negative, yeah, not good for you. You can only get O negative, but you should donate. Okay, you should donate blood if you're O negative, because anybody and everybody can receive your blood. Okay, so now, and you know that's because of the RH factor. All right, so now let's talk about blood transfusion. Okay. Oh, actually, before I do that, there's an NCLEX question I need to there's something I need to do before we get to blood transfusion. I want to quickly break blood down, okay? And there's a reason why I'm doing that. There's NCLEX question that asks you which part of the blood do you give to which patient, okay? So in order for us to be able to answer those questions, we have to break blood down, okay? So blood has different components. There's the plasma component to the blood. That's the part we just talked about when we did the fluid that has the glucose, the sodium, okay. So that's the part of the blood, plasma, okay? Liquid part of the blood. There's the white part of the blood, which is part of our immune system, okay, our little army. There's the platelet part of the blood that helps us not to bleed to death, okay? So its job is blood clotting. And then there's the red blood cell part of the blood that carries oxygen for us to be able to stay alive. Okay, so that's breakdown of blood. So sometimes you get a scenario, you get a question that tells you what, you know, part of the blood do you give the client. So let's go over that real quick. But I want to remind you, there are some plasma values, blood values that you need to commit to memory. Like there's no playing with that. Okay, you need to know the range for your erythrocytes. You need to know the range for your platelets. Like, yeah, sorry, but you got to memorize those values. You knew that. Okay, so let's go over who do you give what part of the blood to. Okay, so the red cells I would give to surgical clients. Okay, trauma clients, they've lost blood. They need that, okay? Anemic client, they need that, you know, oxygen part of the blood, okay? I would give the plasma to your burn clients because it has the protein, right? And all that. So I would give that to the burn clients, your shock clients, your dehydrated clients, okay? Of course, if I'm trying to fight an infection, give immunity, then it would be the white cells. If it's a bleeding problem, then you want to give the platelets. Cryoprecipitate deals with coagulation. So some clients are born with certain disorders that causes bleeding because they're missing the clotting factor 2, 5, 7, or 9. Then they may need the cryoprecipitate part of the blood. Okay. So that's that. So now let's give blood. Couple of NCLEX questions from blood administration. Okay, so often students ask me, can the CNA, or for NCLEX world, the AP, they call them now AP. They used to call them UAP, unlicensed assisted personnel, but now they call them assisted personnel. I don't know why they changed. So I get asked a lot, can the AP pick up the blood from the blood bank? Yes. Okay, so one more time. Can the assisted personnel pick up the blood from the blood bank? Yes. Okay. Thank you for the free webinar. You're welcome. My pleasure. I love this actually, guys. I really do. I can't wait for us to be back face to face. Oh, COVID has been horrible. Goodness, messed up everybody's plan. I like this in the auditorium, seeing you, yeah, but we got to do the best we can with what we've got. All right, so giving blood. So we type in screen Mrs. Jones. Let's say Mrs. Jones is O negative. Oh, well, my picture here says A. That's fine. She's A negative. I kind of make it up as I go along. So Mrs. Jones is A negative, right? So I send my AP downstairs to get the blood from the blood bank. He or she brings it back. So now, let's stop there. NCLEX. If you are not able to hang that blood and get it started within half an hour of when you took it from the bank, you have to return it. One more time. You have 30 minutes to hang the blood from when you picked up the blood. If you're not, for whatever reason, bring it back to the bank. Don't put it in a patient's refrigerator or your unit refrigerator. It has to go back to the bank. Okay, blood bank. So now, before you even, sent whoever, go get your blood, you took Mrs. Jones' vitals. And by the way, vitals that you take pre-blood administration has to include listening to the lungs. One more time. Because we're so used to the blood pressure, pulse, temperature, add respiratory. You have to listen to Mrs. Jones' respiratory status before you go get your blood. So that's part of that initial vital, okay? Silly question, but don't forget it, okay? So now, you did the vitals before you went to go get, your blood. You did the pulse ox, you did the BP, all of that, right? So the blood comes, you can hang it within half an hour. You need another RN to verify that this blood is A negative. It is for Mrs. Jones. Mrs. Jones was typing screen and she is yep, 2 people have to do that, okay? You're welcome. 2 people have to do that, okay? So we got the consent to give the blood, okay, before we even go to get the blood. We picked up the blood. We can hang it in half an hour together with another RN. We made sure, okay, that this is Mrs. Jones. She's A negative. Okay, so we do all of that. Don't forget 2 RNs. And in real life, don't sign these things and run, people, because you are just as responsible, okay, as that other individual. So be, really stop and make sure this is Mrs. Jones and she's getting A negative and she was A negative. Make sure, because we're going to talk about reaction in a moment, because stuff like that kills people. So you can't just and then run. No. Your license that you work very hard for is at risk here. So make sure, this is something you're just as responsible as the other nurse. All right, so you establish your baseline, including your respiratory status, all of that, right? You are not leaving Mrs. Jones, folks. If you're an RN listening to me, you are not leaving. And if you are an LPN listening to me, you cannot initiate blood, okay? LPNs do not initiate. RNs, once Mrs. Jones is stable, because you're doing her vitals every 5 minutes for the next 15 minutes, and then you can do every 10 minutes, every 20 minutes, but every 5 minutes. So you're not leaving Mrs. Jones. But if Mrs. Jones is stable, no reaction, vitals are within normal limits, you can now delegate the LPN to stay with Mrs. Jones and continue to monitor, okay? But you can't leave at first. No. This is one of those clients. You're staying, okay? So transfusion goes slowly for the first 10 to 15, 20 minutes. You don't rush these things. You knew that. And again, every agency I know has the 5-minute, vitals every 5 minutes. So it doesn't matter where you go, New York, Canada, Guam, wherever. That's why you get questioned on that, because that is a rule that is across jurisdiction. Some of you who haven't taken my review before, you probably haven't heard this, but you're tested under NCSBN, so you're tested at what we call a cross jurisdiction. In other words, you will get questions if that skill, whatever it is done the same way for every state. Okay, you will not get questions on skills that are different based on how Jackson does it, based versus Memorial versus BG versus Baptist versus, no, you won't get questions if it differs from hospital to hospital. No, you get question on material and stuff that's across jurisdiction. In other words, it's done the same way no matter what state you go through. And it's good that way, because remember, you can do compact licensure, you can, you know, have several state licensure. We don't want you to have to learn a whole, no, not for something like this. This is routine wherever you go, okay? So, which is great. That's good for us. So some of you want to travel and do your thing, absolutely. And I like that. It should remain that way. All right, so you're doing the vitals every 5 minutes. You're not leaving Mrs. Jones. If she's okay, you can delegate that, okay? We're doing the pulling her CBC, BMP, electrolytes, all of that, okay? We went over the different type of components of the blood. Let's go over reaction. There's 2 different types I need to go over with you, and don't mix them, folks. There's a type of reaction called febrile non-hemolytic versus acute hemolytic. They're very different. Febrile, fever, non-hemolytic, meaning that the red blood cells are not lysing, they're not splitting, okay? So that's usually from a little bit of, it's caused by like a little bit of antibodies to the donor that stays in the unit. Not a big deal. That one, febrile non-hemolytic, is not a big deal. If they even get a fever, it's hours later, okay? 2 Tylenol, move along, right? We're not worried about that. Now, acute hemolytic, that's a problem. You gave the wrong blood. All right, so this is from a true incompatibility, okay? You gave the wrong blood. I actually see the reaction in the patient when I work. Oh, did they live? Yeah, somebody's saying they actually saw a reaction. Yeah, this one, acute hemolytic, yeah. I mean, right away. You see how earlier for non-hemolytic, I said 2 hours later, ugh, not a big deal if you even catch a fever and it's mild. Not this one. Acute hemolytic, right away, the patient will have a fever, chills, low back pain, nausea, chest pain, anxiety. Yeah, you gave the wrong blood. DIC, all of that. The first thing, the priority thing, the initial thing, the thing you'll do before anything else, I don't know how else to phrase that, is to stop the blood. Stop the infusion, okay? Disconnect the hub catheter. Do not allow any more bad blood to enter this client's system. Don't flush the tube, okay? Because think about it, that's more bad blood going into the client. So priority with a hemolytic, okay? A true febrile hemolytic reaction, stop the blood. Okay, there's protocol for this. Okay, we're gonna give oxygen, we're gonna start the diuretics, the antibiotics, the glucocorticoids, yeah, glucocorticoids, all of that. It's protocol. It doesn't matter where you go. Okay, that's the protocol. But first thing, priority thing, initial. That's a silly question that you should have heard if you did a minimum basic. Even somebody doesn't even know what they're doing, NCLEX review will tell you this. Yeah, that's the first thing, best thing, initial thing, stop the blood. Okay, so you won't miss that question. I want to point something else out. Also, you will do what we call an incident report, by the way, because this is an incident. Everything will go back to the blood bank, tubings, everything, because we kind of need to figure out what went wrong. Did we type and screen Mrs. Jones incorrectly? Did the bank give us the wrong blood? Like, what happened? So you're going to do an incident report. And just so, if you haven't heard this before, but if you've taken my review, you've heard this before, if you did the free one, when I did it on management of care, you will do an incident report, but you will not mention in your nursing notes that you did do an incident report. You want to know why? And I will tell you why. Because if Mrs. Jones wants to sue hospital ABC, and in your nursing note, you wrote that you did an incident report, the court can now subpoena your incident report. Remember, incident reports are internal documents. They're not for the public. They don't get broken down with Mrs. Jones' chart. Okay, so keep that in mind. That's a management of care information I just went into here. Why do you have to send the blood back if it is not administered within 30 minutes? Oh, okay. Think of blood like food. It rots. You don't have too much time, and you don't want it in room temperature for very long. But once it gets into the patient, of course, it's gonna, act like their blood. But you don't want blood outside, for very long, because remember, it's in a very special bag anyway, which, keeps its content, because whenever air hits blood, it changes, right? It clots. Okay, you put blood on the table here, you leave it still, it's not gonna remain the same viscosity. So yeah, you only have a certain period of time leaving blood in room temperature. Okay, great question. I like to think of it as food with a very short expiration time. Please help us with the webinar price so that we can participate. Okay, so I have a payment plan that I'm doing, and normally, originally I wanted to go with Quad Pay because I've been researching them. But for some reason, they're not compatible with GoDaddy. My website is with GoDaddy, and I don't want to change, y'all. I don't have time to rebuild a whole new website. Oh no, I'm staying because I have so much other craziness going on. So I'm looking at Spotify, like a couple other entities that will allow payment plan. Okay, so we can do like 200 a week for 3 weeks type of thing. So we can do a payment plan, because I know a lot of you, the thing is I used to do payment plan, but students will just say, without going into the whole craziness, that some people have ruined it for you, because I'm very kind like that, but it just got to be too much. So I stopped the payment plan. I wanted to show you something with antihypertensive, because someone had asked me for it. And by the way, some of you may need little mnemonics. If you need, like, ways to remember the material, the mnemonics are great. I see a few questions coming up. Somebody said we want a discount. Okay, I'll think about it. I have 2 questions. I haven't heard you mention about them. Could you look at this? Can you tell me what the questions are? Somebody said they have 2 questions that I haven't mentioned. Can you tell me what they are? Why do you have to send the blood? Okay, I answered that one. Please help us with the webinar price. Okay, we'll work on the price. Patricia, actually, I seem, okay, reaction, okay, connection issues. Okay, so I think I answered everybody's question. So these are what we call mnemonics. Okay, I have a ton of them that I've collected along the years, and this was a great book here with the lithium, the Jackson. Some of you kind of need to see this because it just helps you remember. Like, that's how I remember it. I'm definitely a visual learner. I'm hands-on as well. I remember things once I do it, but I love mnemonics. I like seeing it, like I'm visualizing it. That theophylline is the long one, so it's 20 microgram versus where the other ones are 2 point, which is a lot, less. Oh, I remember a nursing student had this one. I'll never forget. I love talking to you guys after the test, especially those of you who remember your questions. There was a student who had a question. She couldn't remember the antibiotic. That wasn't her question, but she remembered it was about a pregnant woman. And, I was like, is it quinolone? She's like, yes, how'd you know? It's little mnemonic, people. Okay, quinolones and tetracycline do not mix with pregnancy. They cross the placenta. So the way you remember it is, the way I remember it is with this mnemonic, QT. Anyway. All right, so there's a ton of them. So now you guys know this one. Yeah, with the MAOIs, no cheese, no wine, no pickles. Yeah, so these are little mnemonics to help you remember the madness. So the math, I have a video specifically on math and conversion and drip factors on the YouTube. So now I'll also subscribe, because whenever I do new videos on the YouTube, when you subscribe, it sends you a notice to tell you that I have a new video out there. So please, when you go through the YouTube videos, subscribe. Okay, so now for the math. Okay, folks, I know you don't like when I tell you need to memorize some things, but I'm just a messenger. You do need to commit certain conversions to memory, literally, because you're not gonna be able to look it up on the NCLEX. You do need to memorize that 1 milligram is 1,000 microgram. You do need to memorize 1 liter is 1,000 milliliter. You do need to memorize 1 kilogram is 2.2 pounds. Like, you do need to. There's no going around that, because you can't even let's say you get the question, the math question where you need to convert the child, where they give you the child's weight in pounds, but yet you're giving the drug and kilogram, like you have to 1 milligram per kilogram. How do you do that? You have to convert this child. And if you don't remember that 1 kilogram is 2.2 pounds, you can't convert this child to even know how many milligrams per kilogram you're giving this child. So you got to commit that to memory. And I hate to be the bearer of bad